Old male patient, known case of hypertension on medication, presented to the ER with complaints of central chest discomfort followed by shortness of breath and orthopnea for the past 2-3 days. And there is progressive worsening and he presented to the ER. On initial 10-second assessment, airway is patent, no pooling of secretions, breathing wise 86% in Romeo, respiratory rate of 32 per minute. On auscultation of chest, there is bilateral air entry equal with the bilateral crepitations. So we put the patient in a prop-up position, and also we started on O2 support with a face mask with a 5 liter O2. And
why face mask and why not NRB? Actually, when the patient is desaturating, you can start initially on a high flow oxygen. Actually, you can start at NRB with 15 liters. Then, once patient improves the saturation maintains, then you can de-escalate. Otherwise, you start on nasal prongs, then not improving, again desaturating, again hike up to face mask, then hiking up to NRBM. Rather than that, you can start directly on NRBM. The patient with 15 liters. Oxygen toxicity will not occur in 1 or 2 hours actually. So there is no contraindication starting and then escalating. Rather than that, you go high and then you can de-escalate.
And coming to circulation, BP is 110/60 mm of Hg and heart rate of 100 per minute. And disability, GCS is E4V5M6 and exposure wise febrile. And as an adjunct to the primary survey, we took one ECG. ECG shows T inversions in 2-3 AVF, and which is with T is deep and asymmetrical. And we took one point of care which shows total counts of 12,000 with platelet count of 1,80,000 and HB is 13.2 with a CRP of 25. And we also took one ABG. ABG shows pH of 7.38 with PCO2 42 and PO2 is 58 with a bicarbonate of 22 and lactate is 2. ABG shows type 1 respiratory failure of PO2 58. pH is maintaining. And we also put one top by point of care which shows positive 0.16. And according to the history and depending upon the urgence of survey, there is an ECG shows patient presented with chest heaviness with orthopnea and dyspnea on exertion, which was progressively worsening over past 2 days. With the ECG shows T inversions, deep asymmetrical T inversions in the 2-3 AVF with a tropi positive, and point of care wise is slightly elevated 12,000 with a CRP of 25. And ABG shows type 1 respiratory failure. And
did you do a point of care ultrasound as an adjunct?
Yes, sir. At that point, we do one point of care ultrasound which shows bilateral B lines with no pleural effusion, no consolidation, and we also done one echo which shows mild LV dysfunction, and we also informed cardiology at that point. So from the cardiology side also they done a screening echo in which they showed a MR jet on the color Doppler at the mitral valve area. And coming to the amble history, patient is not allergic to any medications, and patient is hypertensive for the past 10 years and presented with complaints of chest heaviness with shortness of breath, orthopnea, following which there is no history of radiation of pain to the no history of radiation of pain, no history of sweating, no history of palpitation, no history of fever, cough, hemoptysis or syncope, and symptoms started suddenly following an exertion 2-3 days back and rapidly progressed to the severe dyspnea at rest. And there is no prior cardiac or valvular heart disease, and no recent hospital admissions or no prior cardiac surgeries. And there is no history of family history of sudden cardiac death or premature heart disease. And on examination, patient is anxious and dyspneic, and there is no pallor, icterosis, cyanosis and lymphadenopathy, and bilateral mild pitting edema present, and chest has bilateral crepitations, and CVS is S1, S2 hurt, and CNS no focal neurological deficit, and per abdomen soft and non-tender, no organomegaly. And coming to the diagnosis of acute T inversions with acute left ventricular mild dysfunction with MR is there, moderate MR in the screening echo with acute pulmonary edema feature.
So basically you are saying there is an acute NSTEMI
Acute NSTEMI.
and might be a complication like acute MR
MR.
that again precipitated the acute pulmonary
Pulmonary
edema.
edema.
So today's topic of discussion will be acute pulmonary edema. We will discuss NSTEMI, acute MR, the complications in another class. Because basically you have told teen versions in V1,
2-3
2, 3 AV, V1, V2. Okay, with tropi positive. But echo does not showing any RWMA, but it's
RWMA showing only mild LV dysfunction.
LV dysfunction. So we will discuss myocardial infarction as a separate topic. So right now we will be discussing acute pulmonary edema. So before coming to acute pulmonary edema, what is actually cardiac failure as such?
Cardiac failure basically affecting the cardiac contractility of the diastolic or systolic dysfunction of the
Actually, cardiac failure has 3 important points. It's actually a clinical syndrome. Why I will say clinical syndrome, we will discuss later. So it's a clinical syndrome that happens either the inability of the heart to pump itself with blood or to eject the blood, secondary to any structural or functional abnormalities. So basically cardiac failure is a clinical syndrome either due to a structural or a functional abnormality of the heart that impairs the ability of the heart to fill itself with blood or eject blood. That's why we will divide cardiac failure into heart failure with preserved ejection fraction, mid-range ejection fraction and reduced ejection fraction. And again, in cardiac failure patients, we will divide them in different classifications. In ED settings, we have to classify based on the clinical presentation. How you will divide cardiac failure patients into on the clinical presentation?
Cardiac failure patient can be presented with shortness of breath, dyspnea on exertion, orthopnea, PND. Classification
based on the clinical presentation, because when you say pulmonary edema, what we see is most of the pulmonary edema patients are not actually in flash pulmonary edema. They are actually decompensated heart failure. So you have to properly triage them into the clinical classifications. So clinical classifications, we will triage them into either it can be mild to moderate acute decompensated heart failure. Another can be a hypertensive heart failure. Then comes the acute pulmonary edema and finally the cardiogenic shock. So after your clinical, the signs, the symptoms, the examination, as an ED physician, you should triage them into either a patient with mild to moderate acute decompensated heart failure or a patient on hypertensive heart failure or flash pulmonary edema, or the patient is in cardiogenic shock. What we will see is we will triage any patient with history of dyspnea on the background of heart failure, mild congestion, BP might be normal or elevated, with a history 2 to 3 weeks history. We will always triage, we will always take it as acute pulmonary edema. So what is the difference between this mild to moderate acute decompensated heart failure and hypertensive heart failure? In mild to moderate decompensated heart failure, the BP will be in the normal range. The pathophysiology mainly it will be a redistribution, can be the pathology. And congestive symptoms will be more in those group of patients. You will get bilateral curves, you will get B lines, and the severity of dyspnea will be a history of 3 to 5 days like that. 1 week history will be the gradually progressive dyspnea. But otherwise, vitals will be stable for the patient, but predominantly some congestive symptoms, some findings you will get. Whereas when you come to the hypertensive heart failure, the patient is a known case of hypertension, non-compliant to drugs, and the patient right now has a higher BP. And higher BP will be there, whereas the congestive symptoms will be less in the patient. The patient gives history of dyspnea, but on your examination, you will get minimal corrupts, minimal grade of dyspnea. NYHA grade will be on like 2 to 3 like that, gradually progressing. It's the hypertension, uncontrolled hypertension that is causing the symptoms over the time. So that is hypertensive heart failure. Then you come to the flash pulmonary edema or acute pulmonary edema. In those patients, it will be an acute presentation, severe dyspnea, tachypnea, tachycardia, BP will be maybe on the higher side, normal side, and the characteristic feature will be the patient will have air hunger. Once you see a patient of pulmonary edema, you will never forget that patient, because there will be that typical air hunger will be seen in that patient. You will get all the lines, B lines, bilateral curves, everything will be there. Then again, if the patient deteriorates, he will come into the cardiogenic shock. So in this patient, you are saying based on the clinical examination, there is an acute onset, like an occlusive MI was there, that has triggered a mechanical complication like acute MR, that further worsened and led to the acute pulmonary edema, severe tachypnea, tachycardia. You are told bilateral B lines is there in the patient, desaturation is there. So that is acute pulmonary edema. So you must be clear that you are labeling the patient initially into mild to moderate acute decompensated heart failure, or it's a case of hypertensive heart failure or acute pulmonary edema or cardiogenic shock, because the management will be different for all four categories. So now we come to acute pulmonary edema. So what are the symptoms and signs of acute pulmonary edema?
The patient
like flash memory you have said, you can again classify that as forward symptoms and backward symptoms. Forward symptoms can be again fatigue, altered sensorium, like the backward symptoms can be like dyspnea, you will get the right-sided end diastolic pressure increases, you will get the ascites, everything like that. Okay. Then the second thing, what are the investigations you will do in the case of pulmonary edema?
We will do ECG and we will do one echo, and also NT-proBNP can be sent and chest X-ray can be taken. If the patient presented with chest pain, syncope, chest pain, orthopnea and PNT.
Okay, coming to the investigations, before that, what is the pathophysiology of acute pulmonary edema?
Because of the LV diastolic or systolic dysfunction, which increases the pressures in the LV, left ventricle, which radiating to the increased pressures in the left atrium also, maybe due to the structural or functional abnormalities, and that will lead into the fluid filled in the lung spaces like alveolar spaces and interstitium, that will lead into hypoxia and dyspnea.
Basically, it is due to the increased hydrostatic pressure such that there will be fluid leak from the capillaries, the venues that fills in the alveoli, causing the symptoms. What are the causes of this acute pulmonary edema?
Acute.
Basically, you need to understand that you have told the left atrial and diastolic volume increases like that. Because the importance in understanding the pathophysiology is that the treatment depends upon the pathophysiology. Because in 50% of the cases, acute pulmonary edema is the patients are always hypovolemic or euvolemic. It's not hypervolemic. You can say pulmonary edema if the patient is looking dry, dehydrated. Still, you can diagnose a case of acute pulmonary edema, because it is not the volume overload that is causing the pulmonary edema. It is the volume redistribution or the maldistribution. Already the patient is having a volume, and due to some of the pathophysiologies, the volume has redistributed such that the pulmonary congestion happens. So, how volume is maldistributed in the lungs? So, there are three basic mechanisms actually. Imagine the lungs is a bucket, and the body, consider the body as a tank filled with water, and the preload of the heart is the tap water, and your mug will be the afterload and the LV. So there is redistribution. Basically, pulmonary edema is increased fluid in this bucket, that is the lungs. So how can fluid will increase in this bucket?
Increase in the preload or increase in the
preload. So that is one reason the fluid can increase in the lungs. Second mechanism will be
increase in the afterload or decrease in the contractility.
Increase in the afterload. That is the second mechanism. Third mechanism will be
decrease in the contractility or pumping out of
LV dysfunction. It can be either due to the contractility or due to the rate and rhythm abnormalities. So basically any of these mechanisms is affected so that the pulmonary vessels, the pulmonary congestion or the bucket gets filled with water. That is pulmonary edema. It is important because the management also depends upon this redistribution. Our aim should be focusing on decreasing the preload, decreasing the afterload, improving the LV function. So that should be a management. So one thing you have to remember is that 50% of the patients with pulmonary edema are hypovolemic or euvolemic, and the pathophysiology is not volume overload. It is the volume maldistribution. So our treatment should focus on volume redistribution. From the lungs, we have to put volume to the other compartments. So that is the basic things. So then we come to the investigations as per se. So what are the, you told chest x-ray, NT-pro BNP and echo. These are the three major investigations you should do in a case of suspected pulmonary edema. So what are the chest x-ray findings you can see in pulmonary edema?
We can see the bilateral perihilar shadows with periphery sparing can be seen.
Again depends upon the pulmonary capillary wedge pressure. We can stage that into 1, 2 and 3. The initial and the earliest sign of pulmonary edema will be cephalization. Cephalization means the prominence of the superior pulmonary veins due to the stagnation of the blood. That is cephalization of blood flow. That occurs when the pulmonary capillary wedge pressure is between 13 to 18 millimeters of mercury. Then we come to the second stage. Coming to the second stage, you will see the interstitial edema. This interstitial edema, that is the fluid will leak into the septum. There is basically leakage of fluid into the septum and there is thickening of the interlobular septum. This can be visualized as curly B lines. So curly B lines on the second stage, they are parallel lines perpendicular to the pleural surface seen at the lower part of the lung at the lung base. They are seen, periphery and the lung base. Okay, so second stage will be the curly B lines indicating interstitial edema. Third will be the fluid will come and deposit in the alveoli. That's what you call bat wing appearance. They are perihilar opacities and sparing the upper and the lower lobes. They are in the perihilar region. So chest x-ray findings depending upon the pulmonary capillary wedge pressure. Stage 1, when the pulmonary capillary wedge pressure is 13 to 18, you will see cephalization of the vessels. That is prominence of the superior pulmonary vessels due to the stagnation of blood. Stage 2, you will see the curly B lines due to interstitial edema. And stage 3, you will see the bat wing appearance. Okay, those are the chest x-ray findings. So another question is, if you are not finding, you're suspecting a patient with pulmonary edema, but the chest x-ray looks normal, does that rule out pulmonary edema? Chest x-ray has a poor sensitivity for pulmonary edema, but it is highly specific for pulmonary edema. So a normal chest x-ray will not rule out pulmonary edema. It is specific but not sensitive. So the second point you should remember is chest x-ray is diagnostic. It is specific for pulmonary edema, but a normal chest x-ray will not rule out pulmonary edema. Then comes the second investigations. You will do a point of care ultrasound. Okay. What findings are you going to see in point of care ultrasound?
We can say the bilateral B lines can be seen because of...
what are B lines?
B lines are the vertical artifacts which we see in
B lines are basically reverberation artifacts. They are hyperechoic lines that extend from the
pleural line to the base of the
screen, and
it is moving along with the lung sliding.
Moving with the lung sliding. All these criteria should be met to say that it's a B line. In pulmonary edema, what you will see?
You will see 3 or more B lines in between the one rib space can be seen, and it is means all over the areas can be seen in
bilaterally. You will see within the two rib spaces, you will see two or more B lines. What does B lines indicate?
Flow.
B lines doesn't indicate it's pulmonary edema. B lines indicate there is interstitial edema. It can be due to pulmonary edema. That's all. What is lung pockets? When you see more than or two B lines between two rib spaces, it is called lung pockets. It is indicative of interstitial syndrome. It can be due to cardiogenic or non-cardiogenic causes. Cardiogenic cause can be pulmonary edema. What are the non-cardiogenic causes?
Bilateral pneumonia, ARDS.
Bilateral pneumonia, ARDS can be there. Idiopathic pulmonary fibrosis can be there. So, based on the clinical context, you need to attribute whether it is pulmonary edema or not. B lines always indicate interstitial edema. It can be due to cardiogenic or non-cardiogenic causes. And depends on the patient's history, the clinical conditions, you need to attribute B lines to the underlying disease. Okay. Then the third investigation will be
NT-proBNP.
NT-proBNP. What is the role of NT-proBNP in cardiac failure?
If there is any suspicion for the cardiac failure, like if it is in a intermediate probability for cardiac failure, we can send to the NT-proBNP to. If it is a suspicion, we can rule out with the NT-pro. If it is in the lower range.
NT-proBNP has a high negative predictive value. A negative NT-proBNP will rule out cardiac failure. Whereas a positive or a high level of NT-proBNP doesn't indicate, it's not diagnostic of cardiac failure, it will support your diagnosis. The post-test probability of the NT-proBNP will slightly increase if it is on the higher side. That's all. So, NT-proBNP has a negative predictive value. If the clinical context, you are suspecting pulmonary edema and a higher NT-proBNP, you can suggest there is a possibility of cardiac failure. Because NT-proBNP can be elevated in multiple conditions. What are the conditions?
In case of renal failure.
Renal failure, COPD, right ventricular failures, pulmonary artery hypertensions. In all those cases, NT-proBNP will be elevated. So, your management doesn't depend upon NT-proBNP. NT-proBNP just means you can rule out cardiac failure, and also there is a possibility, it's an attributable factor. There is a high NT-proBNP, you can consider cardiac failure as one of your differential diagnoses. That is the role of NT-proBNP. Okay, so 3 investigations you have done. Then in echocardiography, what you will see?
In case of pulmonary edema, we can.
What's the importance of echocardiography? Because we told in the pathophysiology, preload, afterload, and
contractility and rate and
LV dysfunction. So you need to look at the LV status of the patient. So
and any valvular abnormalities also has to be.
So how we look at the LV status of the patient? Initially you will put the parasternal long axis V. Then you will look at what are the parameters you will look to say it is a good LV. Or basically you are putting a probe. You have to say what you are looking. LV status means LV functions assessed by 3 parameters. 1.
As such, the LV chamber contractility can be seen, and also the valvular movements of the septal movements of the valves. It's complete.
Endocardial motion you will assess. Myocardial thickening you will assess. And you will assess the motion of the anterior mitral leaflets. So basically in a echo view, you are assessing 3 parameters. The endocardial excursions, which means you have viewed the LV chamber, point the midline, and all the endocardium should move symmetrically towards the midline, center. That is endocardial excursion. Second thing, you will look at the myocardial thickening. That means during this movement, the myocardium should stretch more than 40%. That is myocardial thickening. Third thing is the anterior motion of the septal mitral leaflet. That means the anterior mitral leaflet come within 1 centimeter of the septum. Then you can say it's a fair LV. So it can be said as EPSS, end point septal separation. So basically in echo, you are looking at the endocardial excursion, the myocardial thickening, and also the anterior motion of the mitral leaflet. Okay. If it comes within 1 centimeter of the septum, the patient is having FARL. Okay, so we have done with the investigations. Then how you will manage this patient?
So initially, the patient, if the patient is in acute pulmonary edema, the patient will be in desaturation and oxygen requirement will be there.
I will give some options. NIV, diuretics, NDG, ACE inhibitors, morphine. First you will select.
Or NIV.
Okay, you will do NIV. Why? Again, we will come back to the pathophysiology. Preload, afterload, LV dysfunction. So how NIV, what is the rationale of using NIV in acute pulmonary edema?
Firstly, it will support for the O2 requirement and also it will shift the fluid out of the lungs. It will help to reduce the respiratory effort of the patient.
Yes, one is decreases the work of breathing. Second,
fluid shift displacement of the
fluid displacement. Okay, so one is work of breathing and the dyspnea, the work of breathing decreases gradually. The sympathetic overdrive also decreases. That is second mechanism. Sympathetic overdrive also decreases. Other important mechanism. First and foremost important thing is the intrathoracic pressure increases such that the venous return decreases. So what happened? The preload decreases. So preload has decreased. Second thing is the transpulmonary pressure gradient decreases such that the afterload decreases. The systemic vascular resistance also decreases. That is second thing. And once the systemic vascular resistance decreases, what happens?
contractile.
The cardiac
Workload will
output
be
also
reduced.
increases. That is another mechanism. And other things are prevents the collapse of the
The lung.
alveoli. Thus helps in the recruitment also. Other things, due to the recruitment, what happens? The ventilation, perfusion matching also increases. And finally what happens? The fluid, the lymphatic drainage of the interstitium is also increased. So that fluid will move from the alveoli. So these are the important mechanisms. So basically what happens? It decreases the preload, it decreases the afterload, and also it helps in better cardiac output. That's why non-invasive ventilation should be your first management in acute pulmonary edema. So Shasya, what are the mechanisms?
First thing is it will increase the intrathoracic pressure, reduce the
Venous
preload,
return
venous
and
return.
decreases the preload.
Preload.
The other thing, it will increase the intra-arterial pressure of
Decreases the transpulmonary gradient and decreases the afterload.
Then it helps in preventing the collapse of the alveoli. Then also it increases the opening
Recruitment. So basically increases the ventilation perfusion matching, decrease the sympathetic overdrive, decrease the work of breathing, and helps in decrease systemic vascular resistance and increase cardiac output. So these are the mechanisms how NIV will act in acute pulmonary edema. So decrease preload, decrease afterload, and also improves cardiac output. Second, what will be your agent? Morphine, diuretics, NDG, ACE inhibitors.
NTG.
to reduce
It's
venous
the-
NDG. Why
will reduce-
NDG and why not diuretics? Because we will use diuretics left and right in patient with volume overload. Why?
Diuretics will help only to remove the
excess.
fluid, thereby reduce the preload. But in case of NTG, it is a vasodilator, so it will reduce the preload and afterload also. If the afterload improves, then the cardiac contractility and output also will improve.
Basically, what you said is correct actually. In acute pulmonary edema, the central circulation is what the body is focused on. So the blood redistributes. Normally, only 20% of the blood will be redistributed to the kidney at the time of acute pulmonary edema. In a normal patient, when you give injection furosemide, Lasix, what do you say, Lasix, when you give, the patient will go into diuresis. Basically, it is the diuresis that is decreasing the afterload. In a normal patient, when you give 40 mg of furosemide, there will be diuresis. But in a case of flash pulmonary edema, the renal blood flow is compromised. Compared to the normal mechanism, only 20% of the blood flow is directed to the kidneys. It is cut down by 1/5 because it is the heart, it is the brain, it is the lungs, majority of the blood flow, the central circulation where the majority of the blood flow takes place. So what happens? When you give diuretic, it won't act on the kidneys. Already the blood flow is low. Second, what happens? The delayed effect will be there. The blood flow is low, so it will take time to act. Studies have shown that 30 to 1 hour will take for the diuretic to act on the kidneys in the case of pulmonary edema. Okay, so and other studies have also shown that rather than when you give in an acute presentation, it will increase the systemic vascular resistance and also decreases the cardiac output. Rather than the benefit, we are getting the side effects of diuretic. So basically what you do is second line, the first line medication should always be NDG. Because why NDG and then diuretic? It will cause venodilatation so that decrease preload. It will cause arterial dilatation. It decreases the systemic vascular resistance such that the renal blood flow is improved. So once the renal blood flow improves, when you give diuretic, it will act. Understand? So first line medication will be your NDG. So mechanism of action, venodilatation, arterial dilatation. Second question will be whether you give it is an IV bolus or an infusion.
Depending on the BP.
Depending on the BP, you can give. Okay, patient is having BP of 160/90. IV bolus or infusion.
If the patient is already on laxis, there will be resistance.
Already on?
Diuretics. The patient has some diuretic resistance if he developed pulmonary edema. So that we have to give more dose of the diuretic to
I am talking about NDG. NDG. There's a study called the high dose CAPE study where they have given IV boluses of NDG. And compared to the intermittent infusions, the IV boluses had better decreased mortality, ICU admissions, and better prognosis for the patient. So, if at all possible, you can administer IV boluses of NDG. Suppose the BP is in the normal range, you are afraid to start IV boluses. Then you can consider adding infusions. If at all you are adding infusions, what is the dose of NDG?
0.5 mcg per kg per minute. We can
Which
start
means how
on
many microgram?
in a 60
For the
kg.
preload effect, that is a venodilatation effect, you need to start at 100 to 200 microgram per minute. And to get the afterload effect, you need to start at 300 to 400 microgram per minute. It is a slightly higher dose actually. So preload effect, you will start at 100 to 200 microgram per minute. For the afterload effect, you will increase the dose of NDG to 300 to 400 microgram per minute. Suppose the BP suddenly falls, what you will do?
You can taper down.
Just stop the NDG. The T half of it's very less. So the BP will pick up easily. So never hesitate in starting NDG. If the patient is normotensive, you can start at 100 to 120, 100 to 200. If the patient is hypertensive, you can start at a higher dose. So second line management will be NDG. So in which all conditions NDG is contraindicated?
The patient is already taking some PD5 inhibitors.
In this case, is NDG contraindicated?
It will increase the MR like
the contraindications for NDG are hypotension, acute MR, aortic stenosis, and the patient is already on phosphodiesterase inhibitors. So once ruling out these contraindication, you can start NDG infusions. Okay, first line you have start NDG. If NDG is not available, the next option will be morphine, diuretics, ACE
diuretics
inhibitors.
already can be given after NTG.
You can go ahead with ACE inhibitors. What is the mechanism of action again? Coming to pathophysiology, again it will cause venodilatation, decreases the preload. decreases the afterload, also causes natriuresis. So what all agents you will use? The recommended agents are sublingual enalapril, sublingual captopril and IV enalaprilat. These are two agents, but in most of the hospitals it will is unavailable actually. So these are two agents that is recommended in the setting of acute pulmonary edema. Sublingual captopril and IV enalaprilat. So these are the two agents. So NDG, if an NDG is absent, then ACE inhibitors, then you will come ahead with diuretic. Understand? So diuretic, as you told, you can start furosemide higher dose. If you are suspecting diuretic resistance, then you can start at a higher dose. Then comes the role of diuretics actually. So there is a study, there is a door to diuretic time. Like I told, if we give initially diuretic, one is delayed effect, the side effects and evidences show that the door to diuretic time, there is not much benefit if you administer early. The chance of prognosis, there is no better effect, no beneficial effect if you delay the diuretic also. So that is diuretics. Then is there a role for morphine? Previously, we used to give morphine in the setting of pulmonary edema.
To relieve the anxiety, we can give that pain and all.
You
And
are
also
giving
it will
for anxiety.
will also cause
Again,
some
studies are saying that when you give morphine as an anxiolysis and you compare midas with morphine, the chance of intubation, the prognosis, the ICU admissions are more with again morphine. So benzodiazepines can be a better agent for anxiolysis if that is your plan of management. Second thing, vasodilatation. Vasodilatation of morphine is basically not due to its effect. It's due to its side effect. How you studied vasodilatation is that when you give morphine, there is histamine release. Due to that histamine release, the patient has dilated vessels, vasodilatation. When you give antihistamines and when you give morphine, the vasodilatation effect is gone. So basically, it is not the effect of morphine, it is the side effect of morphine that is causing the vasodilatation. Okay, so these are the 5 agents. So next time when a patient comes, your management will be, first you will administer NIV, second NDG if there is no contraindication. If NDG is unavailable,
can start ACE inhibitors.
ACE inhibitors, then you will start diuretics. So these are the 4 things you should do in the setting of acute pulmonary edema. So everything rely upon, please conclude in one sentence, this class, everything is based upon
the
3 words.
pathophysiology mechanism, increase preload.
The management, the treatment, everything is based upon the mechanism. The preload, the afterload and the LV dysfunction. And remember one thing, in 50% of the cases, patients are euvolemic or hypovolemic. So hypovolemia or euvolemia does not rule out pulmonary edema. Normal chest X-ray does not rule out pulmonary edema. NT-proBNP has a negative predictive value. It will only increases the possibility based on your clinical outcomes to say it is pulmonary edema. At the end of the day, your aim should be redistribution of the fluid, not the removal of the fluid. And that depends upon the preload, afterload and the LV function. Okay.